My apologies, I've forgotten my spectacles. No. Afternoon, Dr. Croft.
Afternoon, my lord.
Yes, Mr. Gill, when you're ready.
Thank you, my lord. Dr. Croft, what I intend to do for the first session this afternoon is to go through a number of questions that we have had put to us by core participants under our what's called our Rule 9 procedure. And these questions have come from a number of core participants and from different perspectives. We've been made aware of them, and I'd like to go through them. I'm going to go through them in simply in the order in which they have been asked under reference to the topics that have been asked. And I will identify before each question the organisation or person from whom the question originates. So I can begin with a question. It's from Care Home Relatives Scotland. And it's in these terms. From an epidemiology perspective, should the Scottish Government have been aware, as at March-April 2020, based on the available evidence, that releasing patients from hospitals into care homes without testing could have significantly increased the risk of transmission of COVID-19 into care homes? And your answer, sir?
Yes. Yes, and I think to some extent we covered that this morning,
yes.
Did we not, Mr. Gill? Yes, because the patients, if they were coming from hospitals, they may well have been incubating COVID-19 because it was very common in hospitals, so they may not have had symptoms, but they may have been about to develop that infection, and so therefore they were potentially bringing the infection into an environment which by its nature was conducive to spread, and where the residents, the people within that environment were potentially, in the case of the residents, very vulnerable. That was the risk that the government was taking.
Yes. So, just to be clear, that as at March-April 2020, any decision maker who was promoting the release of individuals from hospitals into care homes without testing was increasing the risk of transmission into care homes?
Yes, yes, yes.
Thank you. The second question that I have is from the organisation PAMIS, which represents those who support people with multiple profound and multiple learning difficulties and disabilities. And they set a context for the question, which I'll just go through with you. It is that at page 56 of your supplementary report, and in response to a question from Scottish Care regarding the efficacy of PPE in care homes and or care at home, you state that unfortunately there is a lack of scientific knowledge about what works in these settings. And at page 64, you also state that intimate social care settings may be reasonably analogous to a healthcare setting. Now, just pausing there, I think the last part of that statement is something that with which you would agree, and you did so this morning under reference to what Dr. Tegnell had said.
Yes, it's reasonably comparable.
They go on to say a number of family carers supported by PAMIS provide intimate care to their loved ones with PMLD at home, including medical interventions. Would you consider this to be akin to a healthcare setting? If so, and in light of the scientific evidence available, albeit recognizing the lack of RCTs in social care settings, with the use of face masks, they give the example of N95 respirators or surgical masks, be recommended to reduce the risk of transmission of SARS-CoV-2 in such settings? So perhaps dividing that question up, would you regard the setting that PAMIS puts forward, which with intimate care to loved ones with PMLD at home, including medical interventions, is that akin to a healthcare setting? What's your view on that?
Yeah, I think in general terms, I'm not sure what, I don't know what PMLD is, but I imagine it's something...
Profound multiple learning disabilities.
Profound
multiple
learning disabilities.
Yeah. Yes, it sounds as though that would be a healthcare setting. The family carer is acting in lieu of a healthcare professional under those circumstances. So it just happens that the care has been given in the home rather than the healthcare setting. So it's comparable to healthcare setting.
Thank you. And taking that on, bearing in mind the scientific evidence available, and the questioner acknowledges or notes the lack of RCTs in social care settings with the use of face masks, and they give the example which I've referred to, be recommended to reduce the risk of transmission of SARS-CoV-2 in such settings.
I'm not sure that a blanket recommendation would be appropriate, but it would certainly be appropriate for the evidence around face covering use and its benefits and potential harms, that information was made available to the carers, and it could be in some sort of simple, easily digestible way, so that they could make an informed decision on their own as to whether to wear a face covering. I think that would be the pragmatic solution.
So I suppose underlying that question is whether guidance should have been given in relation to that situation, or whether, following on perhaps from what Dr. Tegnell said, and we discussed it this morning, that should be left to the discretion, the decision of the individual concerned.
I think the latter, of course, professional health care workers were obliged to follow the guidance of the Royal Colleges, like that said, you must, from now on, you must all wear face masks, and so there was no choice there. But at a domestic level, that could reasonably, I think, have been left to the discretion and the informed discretion of the carer, provided they felt there wasn't an imminent risk of infection acquisition from the person being cared for. Then they, I think, could reasonably have not worn a face covering.
And I suppose one would factor into that situation that if it were let's say, a relative who was giving that care at an intimate level to somebody with profound and multiple learning disabilities, probably that person, and I'm sure I'm generalizing, probably that person would be the best person to know how the person in receipt of the care would react.
I would imagine many people in that unfortunate situation would be distressed to see the carer suddenly transformed into a masked figure, and that would be another consideration in the decision as to whether or not to use this form of mechanical barrier, physical barrier.
Right. Can I proceed on to another question from the same organisation, PAMIS? And this heralds, I think, a number of other questions. And I'll put it in the terms that we've agreed from PAMIS, but there may be a need to give a little further nuance to it as we go on. But the question is, what would an RCT in relation to mask wearing and other non-pharmaceutical interventions look like in practice? And would it have been possible to carry these out during the pandemic period? If so, would there have been any practical or ethical issues in relation to this? So can we deal first of all with whether it would, what it would look like? Perhaps you could just explain how one would organise an RCT during a pandemic? Let's say an RCT in relation to the wearing of face masks.
Fine. So here we're thinking about wearing face masks in a clinical setting, or kind of a clinical setting where there's a patient and a carer.
Well, yes. Let's start with that,
Yes.
and then we'll also
Yes.
consider a situation in relation to care at home.
Yes, so randomized control trial is a particular sort of study design that yields very powerful and reliable evidence. And so the first thing is to identify a population that you want to study. So if, in this case, ideally, if the population is loved ones with PMLD, one has to find a population that equates to that. That might be difficult, but they could be sought through social media, for example. So we have to find a volunteer population of individuals and their carers to take part in this trial. And then the question is, what outcomes are you looking for? We're looking presumably for the acquisition of respiratory illness of some kind. And then calculations are made as to how large the trial would need to be, so that you've got sufficient numbers to yield enough power in the trial to answer the question that you formulated. So these are all preliminary considerations where you would probably discuss these with a statistician, and you'd see what had already been done in that field. So you are you're benefiting from other people's experience. You weren't trying to reinvent the wheel. So you then have your randomized control trial pretty much mapped out in your mind. You've identified your population, you've got your volunteers lined up. It would need some funding, so you would need to obtain funding from somewhere. And it would also need ethical approval from a university department, so that might present a bit of a hurdle. So those are all the preliminaries. And from that point onwards, you start to proceed with the implementation of the randomized control trial. And the key principle is you have to randomly assign your participants, who are the patients or the sufferers with the condition. You have to randomly assign them to either being cared for by a carer with a face covering or not a face covering. So that in that way you have two groups. You have your intervention group, who are the ones where face coverings are being used, and the control group where face coverings aren't being used. You then follow them for a period of time which you predetermine. It might be some weeks or months, and during that time, at various time points, you test for the outcome you're trying to establish, which would be something on the lines of whether wearing face masks, face coverings, reduce the acquisition of an infectious disease. So you'd have to think about how you're going to measure that. And you continue until the trial is ended, and then you collate your data and analyze it, and ideally you should then publish it in a peer-reviewed journal so that other people can benefit from your experience. That's very, very interesting. In one of the Cochrane reviewers, they several times refer to a trial of this nature, which they think is particularly well done. It's called LOEB, LOEB 2009, I think. And that was a trial somewhat on the lines I've just set out that was done in hospitals in Ontario, where nurses were assigned to either wear a mask or a respirator, and they were followed for a period of time. The trial started before the swine flu pandemic, but it continued into the swine flu pandemic. So it was actually being done in a clinical setting during a pandemic. And that was a trial that found no difference in infection acquisition between the nurses who were wearing an ordinary surgical mask and those wearing a respirator.
Within that type of trial that you've described, is there not a potential difficulty? And I think this may be what is hinted at when the questioner refers to the practical and ethical elements of it. And I suppose it's a little chicken and egg, I suppose,
yes.
because if you approach the matter from the point of view that, well, masks must be likely to produce some beneficial effect so far as the transmission of a virus is concerned, and you're asking some people who may be compromised in their ability to understand the purpose,
Yes. Yep.
and presumably you would be asking their parents or guardians or other people with powers over them to consent to it. Is there a difficulty that you see in obtaining your control group where somebody is being exposed to potentially a virus without a mask?
Yes, I do see that, and obtaining informed consent is important for randomised control, and this particular study group would pose a problem there, in that they may not be able to give fully informed consent, and so therefore the ethics committee might have some reservations about that. So it might be better to use a study group somehow comparable to this hypothetical group that had full capacity to give informed consent.
Right. Just a moment.
There's a document called the Declaration of Helsinki, which regulates. It's gone into multiple revisions. It regulates the ethical basis for medical experimentation. The Helsinki Declaration came in after the Second World War, when it was realised that experimentation had gone on in Nazi establishments on humans, and this was felt to be wholly unacceptable, and so therefore these safeguards have been put in to prevent experiments being carried out in the name of science on groups who were not fully able to consent to what was happening. So we want to have to be careful here. Yeah.
Can I just ask also about the practical side, or the practical difficulties of carrying out an RCT in the course of a pandemic so that it can be of use ongoing in the pandemic? You've mentioned the various needs to get authority, to get funding. Is there a possibility that the RCT will take too long to be of benefit?
Well, the duration of the RCT might extend beyond the pandemic, but nevertheless it would be a benefit to future pandemics that might emerge. But leaving that aside, even in the pandemic we're talking about, the COVID-19 pandemic, there were a great many RCTs carried out. Then there was numerous RCTs of vaccine efficacy and safety. There were the RCTs of various treatments, or prospective treatments for COVID-19, antiviral agents, and mostly disappointing in their results. And there were some RCTs of physical interventions, such as masks, such as face coverings. I think we talked last time about the two RCTs carried out in Mexico about face, mouth and nasal passage rinsing that were carried out at the height of the pandemic in 2 hospitals in Mexico, and very quickly completed, and the results are quite remarkable. They had no particular funding. They must have had ethical approval, and the findings were important. So yes, it is possible to carry out this type of study in a pandemic, and any number of observational studies were carried out, and often they're not really any more difficult ethically to carry out than randomized controlled trials, but they're just generally easy, more practically more easy, and don't tend to require as much funding or so much statistical input. So research was going on, and huge numbers of studies were being carried out and published, but often of very low quality, unfortunately.
Yes. Now, just perhaps taking up that, excuse me, at that point. We're now some time from the what is generally regarded to be the end of the pandemic.
Yes, yes.
Has there been, to your knowledge, research of the type that you would advocate? Let's take in relation to mask wearing. Has there, so far as you're aware, been any randomised controlled trials in relation to that?
I don't know the answer to that, actually, Mr. Gale. When we last met, I anticipated that when we met again, there would have been an update to the Cochrane reviews on physical interventions, taking into account new randomised controlled trials. But there hasn't, meaning that the authors are still confident in their January 2023 review. I suspect that there might have been some randomised controlled trials, maybe one or two, but the findings haven't been such as to cause the authors of that systematic review to radically change their position or to change it at all. So therefore, they haven't felt it necessary to update the review. So I'm confident. I think I'm confident that that there hasn't been any randomised controlled trial evidence that would alter the position taken in that particular review, either because the trials haven't taken place or because they have taken place, but they just really reinforce what has been said before. And randomised controls are interesting because they will once if they've been done well, it's unlikely that another trial will overturn the finding of the first trial. And I've carried out randomised controlled trials in troops in Kenya. It wasn't to do with COVID; it was to do with malaria. And the first one I did was on with the Grenadier Guards, and I was testing out the acceptability of a particular set of anti-malaria drugs, and I didn't get the results I was really expecting. So I did it again with a different regiment. Princess of Wales Royal Regiment, and I got exactly the same results, which I thought was interesting. Just shows that these are the true results. And so doing a multiplicity of randomised controlled trials isn't always necessary. As long as they've been done well in the first place, you can be pretty sure that the result is going to be is accurate in my experience.
Would you? This is perhaps reflecting the terms of the second question that Pam has put for you. In terms, they ask, is it possible for such RCTs to be carried out after the pandemic period? And if so, how would these be achieved in practice? Furthermore, would there be any practical or ethical issues in relation to this?
Yes, of course, yes. RCTs could be carried out in a non-pandemic time, and that would make life simpler. And the LOEB study that I just referred to had been started in 2008, and it was just in response really to seasonal influenza, which is a recurring problem, and healthcare workers were naturally concerned as to whether they should wear surgical masks or respirators. So that was the question being asked, and it just happened that as they got into the randomised control trial, a pandemic hit, which was a swine flu pandemic, and they carried on nevertheless and came up with the finding that there was seemingly no difference in protection between ordinary surgical masks and respirators in Ontario nurses and nurses in Ontario tertiary healthcare centres at that particular time.
Okay. We move to some questions from the STUC and Scottish Hazards. The first question that they pose is essentially the same question that we've been addressing in relation to randomized controlled trials. And I don't see anything significantly different in what they ask.
Yes.
They do refer to particularly to the wearing of face masks. So I don't think there's anything specific there. But they go on to raise a number of questions about the transmission routes of COVID-19. And again, as the background to this, they refer you to a passage where you said, At the outset of the pandemic, that is in early 2020, a range of transmission routes for COVID-19 was considered likely, with airborne droplets and fomites predominating as the suspected likely routes of transmission, but with aerosols included. You've made that point in your supplementary report at paragraph B24.
Yes.
They ask specifically what month or what date or month do you mean to refer to as in early 2020?
Yes. I think I meant March because by March it was obvious that March 2020 it was obvious that the infection, the epidemic, which then became a pandemic, was spreading very rapidly, extremely rapidly. And in my original report, I had a world map from March, and where is it? This is here. It says March 2020. So this map of the very rapid spread in a matter of months would indicate a pathogen that was not just spread by droplets, just by a bit of muck around people, but also had a certain capacity to spread in the air over and beyond droplets. So as early as that, it would have been generally accepted there was a degree of not simply droplet transmission, but also particle transmission to some extent.
So, from the perspective of somebody like yourself,
yes,
by you're saying March 2020,
yeah,
that route of transmission would or should have been obvious. Well, I'm using the word obvious. It should have been known.
Yes, that there must have been a degree of airborne transmission over and beyond simple droplets. Droplets go through the air, but then they fall. There must surely have been a degree of airborne transmission to account for that rapidity of spread that we see there. Where the whole of the northern hemisphere is almost instantaneously afflicted by this new virus.
Yes.
Yeah. And we're a clean society. We no matter how much cleaning was going on and hand washing was still going on.
It was still going on.
Yeah.
The other question that they pose, as again, is STUC and Scottish hazards. It's supplementary, I suppose, to the question they've just asked, and you've answered. It's in these terms: for how long has it been scientifically accepted that humans emit aerosols, fine particles, when breathing, speaking, singing, coughing, or sneezing?
Yes.
Set inside the question of whether or not those aerosols are infected. Again, the references to B24 in your supplementary report.
Yes.
So are you able to give an indication as to how long that has been known?
Oh, yes. If we could go to the B24 on the screen, I think I know why the question has been asked. Because, thank you. Oh, yes, that's just up a bit. And we need to go up a little bit to B24, up a little bit more, up a bit more, a little bit more up.
I think down.
Oh, sorry. I'm looking. I'm on top of page 24. Top of page 24. Top of page 24. Go down a bit. Yeah, down a bit more. Oh, up.
Oui.
Yeah. Up a little bit. Yeah, there we are. So that box there.
Yeah.
The box there has 5 lines up from the bottom. It says it's got WHO 2021. That this is a screenshot from the Cochrane Review. So inadvertently that's almost like implying that this knowledge became available in 2021. But I think it's in reality it's been known for decades that coughing, sneezing, singing, talking, and certain medical procedures can expel infectious particles. I couldn't put a date on it, but century, perhaps. Century.
I think we, when we were discussing this, in preparation for you coming back, I think you made reference to the adage, coughs and sneezes spread diseases.
Yes. Oh, yes, that was an adage during the 1950s and 60s, I believe.
Wikipedia does have its uses.
Okay, right.
I did look it up.
Yes, yeah.
And I think one finds that it was in fact it was used first by the U.S. military
Right.
following the First World War.
Oh, interesting, yes.
And in the context of the Spanish flu pandemic.
Yes, right.
And there are posters to that effect.
Yes.
And then it was, in the course of the Second World War, was taken up by the British government and indeed other Commonwealth countries. So I think if one accepts Wikipedia as
Yes.
gospel on this matter,
Yes.
it's certainly been available for that length of time.
Yes, so thank you very much, Mr. Gaff. So long before WHO 2021,
Yes.
they've just put it as something that needs to be, it's an obvious point that needs to be stated, but for many decades before that, going back to the First World War, it seems this was known. Thank you, that's very helpful.
Yes, thank you. Can I now move on to some questions from the Royal College of Nursing?
Yes.
They begin with a question about randomized control trials, and in particular your opinion that randomized control trials could have or reasonably should have been carried out. And they asked, do you mean that during the pandemic or following the pandemic to inform future pandemic planning?
Yes, well, both really. During the pandemic would have posed a greater challenge, but it still was something that could have been done and was done in some countries. And following the pandemic, certainly, once the dust had settled, the opportunities there to carry out the kinds of rigorous studies that the Cochrane reviewers recommend and Dr. Ioannidis recommends to shed knowledge on those areas that are still uncertain, where there's still uncertainty, and there are quite a few.
And I think, just to go back, you mentioned the Mexican health workers.
Yes.
Randomized control trials, which I think was something that they themselves organised.
They seem to have organised themselves, yes, and they carried it out to a high standard of rigour. They knew that the answer that they had in their minds could only be addressed through a randomised control trial, and they were done and they were published.
Thank you. The second question from the RCN is a development of the earlier questions that you've been asked. And it's this: if it is the former, that is, that you can do such randomized control trials during the pandemic, do you accept that in a rapidly evolving public health emergency, waiting for RCTs may delay protective action and may expose healthcare workers to unnecessary risk of transmission?
Well, if there was no evidence of anything that was effective, the answer would be yes. But under in the scenario we're talking about, there were measures that were known to be effective, and these were stressed quite rightly and were going on in the background. So what we're really talking about here would be being cautious about introducing new measures which would be either ineffective, so therefore wasting resources, or else might be positively harmful. So I can't see that as a criticism of the idea of having RCTs. There would be a delay before the knowledge became available, but nevertheless, this research wasn't going on in a situation where there was nothing that was effective that could be applied in the interim.
And I think there's two of those protections that could have been applied in the interim.
Yes.
Are two that we looked at this morning in relation to what Dr. Tegnall said.
Yes.
One was social distancing.
Yes, indeed, yes.
And the other was hand washing.
Sure, yes. So going back to the two Mexican studies, the groups were randomized into either using the nasal and mouth rinses with the antiseptic solutions, or not using them. So it was either or. But in the background, they were using PPE, they were using masks, they were washing their hands. So it wasn't as though they were at risk of any greater risk of infection than anybody else while they were doing this important research.
Yes. And these questions are obviously asked from the perspective of a group representing healthcare workers.
Yes, yes.
The final question, not the final question, the next question from the RCN, again, touches on something we've looked at this morning, and it's this: would it not be beneficial for clinicians and patients alike for policymakers to apply a precautionary principle to implementing measures for infection prevention control in healthcare settings?
Yes, we think we discussed that this morning, and we saw what Dr. Ioannidis had to say when he was challenged about that, and he spoke about drivers, and if you were applying a precautionary principle to preventing motor traffic accidents, you'd stop people from commuting. So therefore, a degree of proportionality has to apply there, and equally, you don't insure your house for more than the value of the house. That's the other argument you gave. So, precautionary principles. The precautionary principle shouldn't be used as a means by which you introduce measures which carry concomitant harm that's as great as or greater than what you're trying to prevent. That I think is the answer to that.
And I think also Dr. Tegnall addresses this when he was talking about an overabundance or an abundance of caution.
Yes.
And he said that was a misapplication of the precautionary principle.
He does say that, yes. Yes,
and
indeed,
I think he went on in that passage we looked at to say that there were potentially other harms
yes.
in that situation, and I think indicating probably psychological harms.
Yes.
That and other societal harms that might be engaged.
Yes. So repressive measures like lockdown have to be interpreted in the context of what are they're extreme measures, but at the same time, what has to be considered is what are the extreme unintended consequences, what are the most extreme consequences that can arise from those extreme measures, and this doesn't seem to have happened when they were introduced, partly because it was thought that they would be an instant circuit breaker, but they actually went on and on.
There is, if I can ask you this, yes. Doctor, well, there is probably a difference between unintended and unforeseeable.
Yes, yes.
Would you agree with that?
Yes, yes, of course, yes. It's, sometimes consequences can't be foreseen, but on other occasions they could be foreseen, but just are not really explored, or not explored sufficiently before the measure is applied. I'm thinking of in public health. There was a case where my area of special interest is malaria. In Brazil, they had a massive problem with malaria in the 1950s, and they thought, what we'll do is we'll put chloroquine into the table salt. Everyone's table salt. Well, chloroquine is a very effective anti-malaria drug, and it was a catastrophic error because the levels of chloroquine in people's bloodstream were so low that they didn't prevent malaria anyway. And the parasite, which is a blood parasite, just became resistant to chloroquine, so it became ineffective, completely ineffective as a treatment drug. So there was a well-intended public health intervention on a population scale which had terrible consequences for the whole world, because because that drug then became really not useful for nearly all countries as a measure. So.
Move on, if I may, to another question from the RCN, and this also addresses the question of infection prevention methods. In terms, the question is this: would Dr. Croft agree that infection prevention methods should be applied across the clinical settings, and there should not be a differentiation between, for example, nurses and healthcare workers working within an intensive care unit and those working in general wards? What's your response to that?
I think there has to be some. Well, again, this I think is suggesting a one-size-fits-all approach to infection control, and that surely can't be right. There are going to be some healthcare practices that are more risky than others in terms of infection acquisition, and we've talked in the past about aerosol-generating procedures, so people doing those aerosol-generating procedures, which includes dentists, are going to be more at risk than, say, healthcare staff working on a psychiatric ward where aerosol is not routinely being generated. So I agree with the principle of healthcare workers are all equally valuable. Their health is in all respects equal, but for some there would need to be more rigorous protection of their health than in the case of others. Especially vulnerable group, again, would be in the pandemic was speech therapists who would have to stand in front of a patient and teach them to speak. And I understand the speech therapy just stopped completely during the pandemic because it was considered to be too risky, and there were obviously grave consequences for children and adults who needed speech therapy.
Could we just develop that a little, because the RCN posed the question in relation to clinical setting.
Yes.
Comparing an ICU and work in a general ward. Can we take it out with that situation, and let's perhaps consider the situation of social workers and those who are providing services, maybe not just social workers but social care workers, who are providing services to patients in their own home. Now, some of those services, I suppose, would be very much social services. One could sit at a distance and talk to somebody.
Yes.
One could provide them with meals, provide them with drinks, etc. There might also, however, be situations where, for example, someone is required to palpate the thorax in order to release the mucus or bronchial secretions. Would there be sense in having different PPE and protection given the regard to the nature of what is being done?
Yes, of course it should be based on proper science rather than just conjecture. And I think I'm just trying to remember what the phrase that Dr. Tegnell used. I wrote it down. The Swedish principle of, he calls it, the principle of voluntary action is what he calls. So voluntary action informed by good information, by reliable and science-based information, could be applied there, and I guess professional bodies could be empowered to direct that their members could take a range of could apply a range of measures to protect their health without it being something that would be dictated from above by the government. That I think is what the Swedish approach would have been in this situation. Okay. And it would be a sensible one, I think.
Thank you. The next question posed by the RCN, there are a number of questions posed by this organisation. The next question is references question B4 in your supplementary report, where you mention that there is, quote, no scientific consensus, unquote, regarding whether SARS-CoV-2 is transmitted by either droplet or that it is airborne.
Yeah.
And then the question is put, would you not agree that the early focus on droplet transmission may have led to underprotection of healthcare workers and care home staff, as it was found not to be the only mode of transmission, and those representing nurses and healthcare workers were raising the point about airborne transmission and seeking appropriate protection in light of that? So there's a number of aspects to this question. First of all, is the question that I suppose in the early days of the pandemic, the focus on droplet transmission may have led, as they say, to underprotection of healthcare workers and care home staff. And I think we discussed this morning, if I may just again set a little context, we did discuss this morning a little about the knowledge about the mode of transmission and the difference between droplet and airborne transmission, and you gave your view on that. Do you feel that the early focus on droplet transmission may therefore have led to underprotection of healthcare workers?
Well, I think the real question is what protection should have been put in, and if what we're talking about is masks. Healthcare workers were generally, by their own colleges, obliged to wear masks anyway, so I don't really see what the drift of the question is. Perhaps you do, Mr. Gilbert. Maybe you could help me.
I think it may perhaps.
If it's a question, I'm so sorry. If it's a question of should they be worn respirators rather than masks, then the answer surely is no, because we have trials such as a LOEB study in Ontario that demonstrated that respirators in an acute and emergency setting in a pandemic were not any more effective than masks in preventing the acquisition of acute respiratory illness. So I'm a bit uneasy about this question.
Yes. I suppose if one extends it to not merely those working in the healthcare setting, but those working in care homes.
Oh, yes.
And possibly care at home.
Yes.
Again, would the early focus on droplet transmission suggestion that the mode of transmission was not airborne, would that have potentially led to workers within the care home sector and the care at home sector being unnecessarily exposed?
Yes, possibly. I'd be surprised if workers in care homes were not wearing masks from the outset. That would surprise me. But again, maybe there's a sense amongst healthcare care home workers now that they should have been wearing respirators early on and weren't. But my view is that wouldn't have given them any additional protection.
I see.
Of course, care homes don't have a professional body in quite the same way as nurses or physiotherapists, so there wouldn't have been a professional body saying you must wear surgical masks at all times. So it may be that in some cases they didn't, so as not to cause too much anxiety amongst their residents. And yes, okay, I could see that perhaps the emphasis on hygiene and cleanliness might have led to some complacency around proper mask wearing.
I suppose also there is inherent in that question from the RCN that, and we've heard evidence from the RCN that at an early stage in the pandemic they were advocating that the likely route of transmission was airborne, and therefore they were, as it were, advocating on behalf of their members that there should be that level of protection. Again, and this may not be within your remit or your knowledge, but where an organisation representing those at the front line of healthcare are advocating for that, what do you think would be the force of those representatives so advocating?
Well, I would anticipate that if it's a scientific organisation like the Royal College of Nursing, they would have citations from randomised controlled trials and systematic reviews of trials to support their thesis, whatever that might have been. I don't quite know what the thesis was, and maybe they did, and the evidence was disregarded, in which case that's unfortunate and deplorable, in fact. But if it was just an advocacy based on gut feeling, then instinctive feeling, then I can't see that it would have necessarily carried much weight, nor should it have carried very much weight, even though they might have represented the gut feeling of several 100,000 members. The numbers are not the important factor here. It's what the science actually, the rigorous science actually demonstrates that should count.
I think that this is asked against a background where the WHO was somewhat late in confirming the airborne transmission of SARS-CoV-2. Is that correct?
I don't think they were late in confirming the airborne. They were late in confirming whether masks should be used in the community, which is fine because, of course, the evidence, there wasn't any evidence to suggest in the community as such it had a significant impact for a number of possible reasons. But towards the end of 2020, they did recommend masks in the community, and that was when the Bangladesh study was underway, and I presume they anticipated that it would demonstrate beyond doubt the benefit of wearing masks in the community, but it didn't, in fact. It didn't.
Again, this is a connected question, again from the RCN.
Yes.
And takes as a datum
Yes.
that the position was being advocated by those representing nurses and healthcare workers on the question of airborne transmission. And the question is, would you not agree that if there are measures which can be implemented at a clinical level, even where scientific consensus has not yet been reached, where it can be seen that there may at least be some benefit, there may be at least benefit in implementing those measures, it should be done at the earliest stage?
Well, no. If there's a potential for there to be harm, and if there's a potential for there potentially to be extreme harm, then the answer, I think, is no. But if there was benefit without any possibility of harm, then yes. So the harms have to be considered, and also the worst-case scenario for the harms must be taken into account when implementing measures such as this. So in the example of the Brazilian salt that I gave, nobody had thought, gosh, maybe this is going to have a terrible rebound effect. It seems to be harmless, but in fact there was a grave potential for harm to result from that simple, well-intentioned but misguided intervention.
Again, perhaps developing on from that question is the next one from the RCN, which is, given the evolving understanding of airborne transmission, would you not accept that IPC guidance should have been updated more rapidly to include and reflect this?
Again, I think this, I'm not sure what the subtext is of this question, but if it means updated to include the use of respirators in addition to masks, then I would say no. But generally, guidance in general, infection prevention and control guidance should be updated regularly to take into account new knowledge as it becomes available. So the general principle of updating guidance rapidly, I do agree with.
Yes. So if I can put it this way, once it had become reasonably apparent
Yes.
that aerosol transmission was a factor,
Yeah.
would you agree that that should have been taken into account as soon as possible?
Yeah, I'm sure a lot of nursing time was wasted on cleaning environmental surfaces, and now that's considered to be less important than it was seen at the time. So that shift towards airborne in a general sense rather than fomites as a major vehicle for the acquisition of COVID-19 could have been perhaps better publicised, and there could have been some scaling down of the environmental cleaning, decontamination regimes that were going on. So that's where I'm thinking guidance should have been modified early. Perhaps it was in some institutions, not in others.
Can I ask, in that that situation, would you have envisaged that there would be improved ventilation?
Oh well, yes. Well, once it was apparent, as it was earlier, that the transmission efficiency was much less in outdoors than there ought to have been, and I'm sure there was in many hospitals and healthcare settings, an emphasis on fresh air. Just simple measures like keeping the windows and the doors open should have been strongly encouraged, and where resources allowed, even mechanical ventilation might have been promoted as a means of circulating the air indoors, where there would be the greatest potential for disease acquisition. So yes, that's thank you, Mr. Kelly. That's a good point.
Thank you.
And on that, of course, many GP surgeries used to conduct many GPs conducted their surgeries in the car parks during that time on favourable days, which was eminently sensible because they could see the patient, they could to some extent examine them, and the risk of disease transmission either way was greatly lessened by the outdoor environment. So they were like open air surgeries in effect.
The next question from the RCN is relates to care home settings, and this is put in contradistinction to hospital settings.
Yes.
And inclusive of care homes and nursing homes. Mm-hmm. And the question is, do you consider the proposition that if AGPs are the likely route to infection spread, that such risks are inherently likely in care home settings?
Yes, I had a list of AGPs, an indicative list. It wasn't a complete list in my original report, yes. On page 18, and this is what I put. So I took it from, where did I get it from? Davidson's Principles of Medicine. So Davidson's gave a list of AGPs that would potentially give rise to a heightened risk of COVID-19 transmission, and they said dental surgeries, aerosol-generating procedures commonly take place in hospitals and in dental surgeries. This is an exact quote that I used, by the way. Hospital procedures in this category include, but are not limited to, tracheal intubation, so that's putting tube down the trachea prior to anesthesia, and manual ventilation, non-invasive ventilation, and the use of certain high-flow oxygen treatments. They all sound quite high-tech to me. I'm not sure any of those would be taking place in care homes. They would be likely to take place in the hospital. And only a certain branch of the hospital as well. So I don't think the answer to the question is that care homes don't seem to, in my mind, be common places where aerosol generating procedures occur frequently, but there may be some care homes where they perhaps.
Can we put the rather crude example of somebody being palpated in order to expectorate?
Yes, indeed. Well, that's a physiotherapy type of task. And there may be physiotherapists. There'll be some large care homes that have they employ physiotherapists to perhaps with patients residents who don't have important nursing needs but might benefit from a bit of physiotherapy, including chest physiotherapy. So that wouldn't generate aerosols to a great extent. I don't think it's not included amongst the list Davidson's has.
And might also, you were talking about the specialty of physiotherapy.
Yes.
But might also it be the case that a nurse within the care home setting or the nursing home setting might find the need to do that as part of their duties, as one was caring for the individual.
Care home settings, strictly speaking, don't employ nurses; they employ carers. But there may be a nurse that comes in to do. Yeah, nursing homes would employ staff nurses and charge, and maybe perhaps a couple of staff nurses and carers. So there might be complex procedures that, but certainly in these establishments there would be face-to-face contact occurring quite commonly. But in the strict sense, aerosol generating procedures, I don't think are a common aspect of these very important establishments.
We have also got the possibility of what we've looked at already: coughing, sneezing.
Yes, yeah, of course. Yeah,
those sort of situations.
Yes,
and I think what the RCN is asking you to consider is that, given your view on AGPs in the hospital situation, would you not accept that care home and nursing home settings are, by extension, given the clinical need and the input in relation to many residents, at least some of whom will have been in hospital during the pandemic, are similar enough to a hospital setting to fall broadly within the character for PPE use?
Yes, so these are aerosol generating procedures with a small a, really, or aerosol generating activities, which is coughing and singing and breathing. It's breathing, coughing, singing, sneezing, and whatever the other one was, talking. So just the very fact of being alive, as I'm talking now, they're generating aerosols. But the aerosol generating procedures that are technical procedures occurring in hospitals is somewhat different. They generate, I think, massively infective aerosols, or the potentially massively infected aerosols that are travelling at speed and could deliver potentially a very large infective load, potentially to whoever was in the vicinity. Mm-hmm. So if we think about them as small, lowercase aerosol generating procedures, they're happening all the time. They're happening in nursing homes and care homes, but the uppercase aerosol generating procedures are happening mostly in hospitals, but only in certain departments of hospitals and dental surgeries.
I think the next question from the RCM is probably one you've just answered.
Ah, right.
But it's, do you consider or do you accept the nature of the work being carried out by healthcare workers in care homes has the potential to bring them with close, repeated proximity, should be within close, repeated proximity of COVID-19 if the residents are infected?
Yes, because they are employed to deliver care, and the care is of a personal and physical and proximate nature.
Yes. Moving on, if I may, to the next question from the RCN. You have stated at B20 of your supplementary report that the input of organisations such as the RCN and others could be used to formulate a precise research question which could be used as a basis for an RCT. would you accept, reading on in the question, that in the absence of that evidence or those trials where the pandemic and risk of infection presents a current and real risk, that there would be benefit from engaging with these organizations in discussing infection control mechanisms to ensure transparency and take the views of those who are fighting the pandemic on the front line? Again, it's a quite lengthy question, quite involved, but essentially, again, it takes as a datum the role of nursing practitioners, whether in, I suppose, both in hospitals and in care homes, that effectively their experience and the experience which had been passed to their representative organizations could be used to provide the basis for an RCT.
Yes, it would certainly be helpful in when designing an RCT that was planned to take place in a specific nursing setting to seek the advice at an early stage of some practitioners who were in that setting, so that it was designed sensibly, and that's called stakeholder consultation, I guess. Yes. So in other words, you're designing an RCT that really does address the concerns that that particular target group has. Yes.
Without suggesting any criticism.
Yes.
Representative organizations have the interests of their members at heart.
They do.
And they have a particular, they will be coming from a particular perspective.
Of course.
And I think what you're saying is that it would be good to have a range of stakeholders,
yes,
who were inputting into
yes,
the modelling of an RCT.
Yes, 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 yes. And you listen to the stakeholders. You don't necessarily apply what they have said, because there's a range of stakeholders, and some of the advice you're receiving might be contradictory. But it would certainly be most helpful to get the feeling of those individuals who potentially would benefit from your research.
The final question from the RCN, at least from me, there's one will be one from Mr. Edwards, is in relation to is what you said at page 24 of your supplementary report, where it states, in summary, at the outset of the pandemic, that is in early 2020, a range of transmission routes for COVID-19 was considered likely, with airborne droplets and fomites predominating as the suspected likely routes of transmission, but with aerosols included. I think we've already quoted this.
Yes.
And the question is, can it be accepted that by early 2020, policymakers were entitled to reach the conclusion that COVID-19 was, therefore, spread by both routes?
Yes, and I think they did reach that conclusion. I believe they did.
Yes. Yes. Can I go now to a number of questions from the group Bereaved Relatives Scotland Sky? And again, these are somewhat, they reflect some of the questions you've been asked, yes, and already answered. The first is a slight modification. It's in straightforward terms. Would it be possible to conduct an RCT in a care home environment?
Yes, provided the participants, both presumably the staff and the residents, would be participants, provided the staff and resident participants could give informed voluntary consent. There was no coercion involved. Yes, certainly.
And then progresses on, what would be the risk of conducting an RCT in a care home environment?
There'd be no risk. It would contribute, importantly, to the knowledge base around safety in that environment.
Again, speaking, I suppose, counterintuitively, if one was looking at, for example, face masks,
Yes.
and putting the result of the RCT before, and I know this is not something you would be interested in doing, but putting the result of the RCT on an intuitive basis that face masks would assist in the prevention of the transmission of the virus. Do you think that would be a disincentive, and I put it as low as that, for a group to take part in an RCT within a care home environment?
Well, it would depend on how the RCT was designed. So potentially it could be designed with one arm having no face masks, or one arm having and the other arm having face masks. Or another alternative might be the Bangladesh approach, by which one group might have face masks and a video and be taught how to change the face masks very carefully. The other group might just get given face masks. So there would be ways potentially to design it so that any objections of that nature, fundamental objections, would be assuaged. And this goes back to the point about consulting with the stakeholders early on to see what it is they're concerned about.
The next question is, again, I think probably one that you have already answered, and I'll put it to you in its terms. It's if the risks of conducting an RCT in a care home environment can be managed. Should RCTs be carried out in care homes? If yes, how should they be carried out? I think you've said yes to the first part of that,
yes.
And you've indicated just in the last question how that would be done.
Yeah, ethically and safely is the answer, really. Yes.
The next question from that group is: are care homes to be considered as healthcare settings?
In the broadest sense, yes, because they're delivering care at a psychological and basic physical level: food, drink, hygiene, and companionship, and entertainment. But not healthcare in the sense, care homes don't generally have people with complex nursing needs. So care homes are generally, the American term is retirement homes as opposed to nursing homes. So care homes are healthcare settings, again lowercase, but not in kind of a formal uppercase sense.
If one is looking at a care home setting where there is a preponderance of residents who have dementia, would you change your view on that?
Yes, I guess there would be dementia nurses there. Yes, so there are. I'm sure that there's a fine distinction between what's a care home and what's a nursing home, but my understanding, my wife is a nurse and she's been staff nurse in charge of nursing homes, and my understanding is if the person in charge is a nurse, it's a nursing home. If the person in charge is a carer, but not a nurse, then it's a care home, even though nurses might come in to attend to specific patients, like district nurses, for example, changing their diabetic wounds and so forth.
Rod, I've only got two more questions to ask in relation to this. So, the next question is: did face masks offer any significant protection in the care home setting? Again, I think probably you've answered that, but and I think you've done so under the reference to the Cochrane review. Is that right?
Yes, we don't know. There's no evidence that they offer significant protection in It would depend on quite what the nature of the home was. if they were being worn correctly, they would have offered protection, probably. But the actual setting of a care home and how risk can be mitigated there is not hasn't happened. That research hasn't happened in that particular setting. So it might or might not be possible to generalise results, findings in hospitals to care homes. It would just depend on quite what type of care home it was.
And I think you will probably refer us back to the Bangladesh.
Yes, with Bangladesh, though, that was villages were being compared with other amongst other villages. So it was a community experiment, and I just have to. So the villages. I just have to refer back to my original report. Is conducted at the end of 2020. The 600 villages were randomised into either villages where they were wearing a mask and were shown a video and a brochure on how to use them, or else there was no intervention. So they might wear masks, they might not. And in that trial, which was a very good one, pragmatic one, large one, there was no significant difference between the villages where there was a full-on attempt to get them to wear masks properly, and the ones where they were just left to do their own thing.
The final question from the RCN does overlap with another issue. But I'm sorry, not the RCN, from Bereaved Organisation and Sky. It's in these terms, during the early stages of the pandemic, how feasible would it have been for testing to have been carried out on hospital patients prior to discharging them back into care homes? Was suitable testing available during those early stages?
No, there was a shortage of testing capacity then, and Dr. Tegnell, of course, referred to that when he said they prioritised testing. I can't remember who was top priority, but there was a limited number of tests available. So I imagine that the priority was for hospital patients who were inpatients and hospital staff as well. And those patients were being discharged because they were clinically well back into the community, which could have been their own homes or could have been care homes, were not considered to be priority for testing when testing was so limited.
Mm-hmm. The question itself is directed towards the feasibility of such testing. Can I swap the word feasible for the word advisable?
Oh, it would have been advisable, yes, of course. But it may not have been possible because of lack of tests.
Yes. Well, that's the end of the questions I have, so we can take a break.
Yeah, thank you. We'll take a break and come back just a few minutes after 3 o'clock. Thank you. Now, again, Mr. Gale, Dr. Croft, when you're ready. Oh, I do beg your pardon. Oh, that's
My Lord, thank you. Dr. Croft, as my learned friend said this morning, I'm going to deal with themes E, F, G and H, which were originally 5, 6, 7 and 8 in the questions put to you, and we'll stick with the alphabetical lettering, given that that's how your report is organised. There might be a little bit of going back and forth into the earlier themes, as has been the case when Mr. Gale has been questioning you. Perhaps if, in my case, I will be asking you just to comment and elaborate on some of the answers you've given in your supplemental report, given that in light of some of the discussion between you and Mr. Gale this morning, arising out of Dr. Tegnall's book,
Yes.
and the Ioannidis paper. I'm not going to ask you all the questions that were put and the answers you were given in your supplemental report. And it's not necessary to do that because your supplemental report is before the inquiry. But if I could just ask you about the first question, which is E1. So this question was put by the Scottish Health Board's National Health Services, I think Scotland, Healthcare Improvement Scotland and Public Health Scotland. And your CV is, of course, one of the annexes. I think it's Annex 2 to the supplemental report.
Yes.
Annex 1 or Annex 2.
Yeah.
But and in that you set out your public health expertise.
Yeah.
And you give quite a detailed response there. But can I just ask you to put it briefly in your own words what you would say the highlights of your public health expertise are?
Well, even before I became a public health physician, I was a general doctor. I trained in the NHS, in an NHS hospital, NHS medical school, and then worked for a while in the NHS. Then I did join the army, the military, then started specialist training in public health, much of which training was within the NHS. Having qualified as a public health physician, I then applied that training to my immediate population, which was the military and their dependents. So there were families as well, and the same sort of families as you get in the NHS environment. And I'd, as is a requirement for consultants, in due course I became a consultant, we had to do a certain number of continuation training. It was a minimum of 50 hours a year, but the recommendation was 100 hours of continuation training a year. And a lot of that continuation training I did in the NHS, attending NHS conferences, often came up to Scotland, to Glasgow and Edinburgh for conferences. And so I was in constant contact with my NHS colleagues. I sat on committees for my faculty where I was military representative, but the others were mostly NHS. So I'm very familiar with public health as is practiced in the NHS.
Yes.
Is my answer to that question.
And of course you're also a doctor.
I'm a doctor, of course.
Yes. Now, the title of... I am about to put some criticism in a letter that the inquiry has recently received, but before I do that, it's relevant just to set the scene of the title to this subject matter. And if we see in theme E, the title is Evidence-Based Medicine versus Outbreak Management.
Yes.
And as I said, I'm not going to go through all the questions, but a theme of quite a number of them, and indeed some that my learned friend put to you earlier this afternoon, is that there is an opposition, or at least a tension, between evidence-based evidence-based medicine and outbreak management. Is there a tension, or are they in opposition, or do they address the issues that arise in a public health difficulty together?
No, I think outbreak management has to be based on evidence of what works and what doesn't work, and if it doesn't, then it's straying away from what science should be about. Science should be about knowledge and also uncertainty, and outbreak management has to steer a careful path between those two poles, and there shouldn't be too much reliance on uncertain methods of action. There should be, as far as possible, reliance, preferably complete reliance on methods of dealing with the outbreak that are proven and scientifically proven.
Yes. Annex 4 to your report sets out key epidemiological concepts.
Yes.
And given what we're about to talk about, evidence-based medicine,
Yes.
is, you define it there.
Yes.
So for present purposes, do you just want to try and capture what is meant by evidence-based medicine?
Yes, thank you, Mr. Edwards. Yes, I think it's terribly important. It's relatively modern concept by which it's a system of intellectual inquiry that recognises that in the field of scientific research, there will always be a hierarchy of evidence, scientific evidence, where some evidence from research has to be considered to be more reliable than other evidence from research. And the least reliable evidence will typically be a single case report that might be published in obscure journal from a practitioner who's just tried one type of treatment and has found that the patient recovered. That would be unreliable because it would be considered anecdotal evidence. So there is a pyramid of evidence with a lot of poor quality studies at the bottom, gradually rising in terms of their scientific credibility and rigor to what is considered the gold standard of evidence, which is a randomized controlled trial, which is relatively few in number compared to the number of observational studies, poorer quality studies, because they're sometimes easier, they're often much easier to do quickly and cheaply. But the randomized controlled trial should really be the linchpin on which good clinical practice, which includes public health practice, is based at all times, including when outbreaks are happening.
So randomized controlled trials are, you describe them as the gold standard.
Yes.
I mean, earlier in this afternoon, when you were giving evidence, you mentioned some experience you had with an RCT in Kenya, I think, in relation to a treatment for malaria.
Yes.
And I noted down that the RCT failed on 2 occasions. Is that what you
No, it didn't fail. It just I was thinking that it would yield a particular result, but it didn't actually give quite the result I wanted.
Right.
So I changed. So I repeated the trial with a different regimen, but actually they were the same demographically, exactly the same as the first regimen. So I should have realised the result was going to be the same. And I slightly changed the two drugs. They were standard licensed drugs. They weren't experimental drugs. They were taking for malaria, thinking I'd get a different result by, if you like, manipulating the figures. But it was the same result, which shows that they will the nature of randomisation and blinding that. The participants were blinded, reduces the kind of biases that come into observational studies, where people will often like a particular medicine because it's blue or because it's kind of jelly form, whatever. So factors that are strictly relevant to what's actually being asked will often muddy the results in non-randomized, non-blinded trials.
Yes.
So to be cruel, it was your conjecture that failed, not the result.
It was my attempt to, I suppose, my attempt to slightly massage the data that failed, but I was defeated by the rigour of the methodology I was using.
Yes, but would it be fair to say to a layman like myself that supports the strength, the gold standard nature of the RCT?
Indeed, and in fact, this was early in my training for public health, we were required to do 2 large projects, preferably one of which being infectious disease and one non-infectious. So I was given this study to do. I didn't really want to do it. I wanted to look into Legionnaires' disease, but I was told to do malaria instead. And I was going to do an observational study, and I was discussing this with Professor of Medicine at Oxford University.
Don't name him.
He's retired. He said, no, you mustn't do an observational study. You must do a randomised controlled trial. I said, oh, no. He said, no, randomised controlled trial. So I did it. It was quite complicated to do, but it gave results that were credible, whereas the observational study would have given results that might have been of some interest, but would have needed to be tested through a randomised control trial afterwards.
Yes, and as we saw from the excerpts from Dr. Tegnall's book, he, like you, supports the gold standard nature of an RCT.
Yes, he doesn't spell it out explicitly. Dr. Ioannidis does, but I'm pretty sure that's what I'm very clear that's what Dr. Tegnall is when he's talking about evidence and the knowledge base. It's axiomatic that in medical practice nowadays, evidence means evidence from good quality studies, which means RCTs and systematic reviews of RCTs.
Well, I mean, that segues into a letter that was received on the 17th of September 2025 from the College of Paramedics,
yes.
Which takes a different position.
Yes.
And it's right that we give you an opportunity to respond to it. I mean, it will eventually appear in the record. Yep. So this was, I say, a letter received from the College of Paramedics, and I'm not going to read it all out, but what they ask, first of all, is that they say that they believe that a number of your responses in your supplemental report do not adequately reflect the breadth of scientific knowledge that has emerged during the COVID-19 pandemic, and critically, I'm quoting, critically, rely too heavily on the narrow view that only randomised control trials provide reliable evidence. Do you want to comment on that?
Yes, I've written a draft response. Can I read from it?
Yes.
My Lord?
With my Lord's permission. Yes.
Yeah, I only got this late on Friday, so it's quite late in the day. So it's the College of Paramedics letter, three-page letter,
yes.
Addressed to yourself, Lord President. And then I had a reply that I sent by email. Just a one-sentence reply. Could be in here. In reply, I actually cited the textbook, Harrison's, which I've got. Okay.
Just struggling to find it. I think Mr. Gale may have it. You don't?
Sorry. This is Colin.
Oh, there we go.
Yes.
Good. That's on. I forget.
I've seen it.
Oh, okay.
So rather than read it out, if you could address that point,
yes. Okay.
that your work for present in the supplemental report relies too heavily on the narrow view that only RCTs provide
yes.
reliable evidence. If you could deal with that point first.
So in my former reply to the letter, I just said I welcome the arrival of this letter because it enables me to re-enunciate the principles of evidence-based medicine, which I think I've just done. And it's not correct to say that there are other equivalent methodologies that are as good as randomised controlled trials. There just aren't. This is not modern science. Randomised controlled trials are the pinnacle of reliable evidence, and other study designs are often helpful for helping to formulate research questions, but those research questions are only questions, and they then need to be addressed through randomised control trials.
So you're not excluding other studies or observations?
No, I think it's admirable that a multiplicity of studies have been done, and the textbook I quoted, Harrison's, which is a standard textbook that's the most authoritative in the world, said that a vast amount of research had come out. And it says more than 40,000 publications about COVID came out in the first 7 months of the pandemic. An enormous amount of uncertainty still remains, and it says that these observational studies often have many limitations in validity, but nevertheless they're useful because they say this is what's said, and I agree entirely. They will they have no role in formulating modern standards of practice. These observational studies, no role in formulating modern standards of practice. Nevertheless, they can be useful for generating important hypotheses, or be the first reports of an adverse event or therapeutic benefit that then has to be tested using randomized clinical trials. So So the position I've taken, that I've expressed from the outset to this inquiry, isn't in any way peculiar to me. It's basically standard modern science, which all
comparison. So if I simply repeat that for the record,
Yes.
the inquiry already had sight of it, but I think it would be helpful if that could be formally admitted to the inquiry record, please.
Yes,
Mr. Edward.
thank you, my lord.
Very good. Now, on you go.
Yes, so without mentioning any particular examples of studies, to remind you, Dr. Croft, Lord Brailsford, as chair of the inquiry, received a letter from the College of Paramedics containing some criticism of aspects of your supplementary report. And one was that you rely too heavily on the narrow view that only randomised controlled trials provide reliable evidence. You answered that on the basis that they're, if I can put it in my own words, that these are the gold standard, but you're not excluding other observational studies or laboratory-based experimental research as contributing to the state of knowledge.
The randomised controlled trials are the only source of reliable evidence.
Yes.
The only source of reliable evidence for guiding clinical practice, which includes outbreak management. Other studies can contribute in the sense that they can help to formulate hypotheses, research questions that can then be answered only by randomised controlled trials. So they're not two parallel and comparable methodologies. One is definitely superior to the other, is my response to that.
Yes. So if the College of Paramedics say that your stance overlooks the contribution and practical relevance of well-designed observational studies, laboratory-based experimental research and other rigorous applied methodologies, and they say such a position, in their view, is problematic within the context of a comprehensive and robust scientific inquiry.
Yes, well, first of all, I reiterate, Mr. Edwards, thank you. I'm grateful to the College of Paramedics for allowing this debate to take place, because it's not a debate, it's an exposition of what is the standard position of medical science nowadays, today, and it's not a personal position of mine. It's taught to all medical students and to all doctors in their specialty training, and that is that the very best sort of evidence is that derived from randomised controlled trials. On ward rounds, consultants nowadays will ask their juniors, are there any recent RCTs about this treatment? And then they'll quickly check up on the phones and say, no, there aren't. Yes, there are. So it's now embedded in clinical practice that you look for evidence from randomised controlled trials only in terms of guiding your practice.
Right, thank you, Dr. Croft. This question may be a little bit easier, or criticism rather. The second criticism is that you've given inadequate consideration of cardiopulmonary resuscitation as an AGP. That's in answering question B13 of your report. Now, you've acknowledged that you're not an expert in CPR, but the College of Paramedics says that, in their view, your answer in B13 significantly underestimates the established risk of aerosol generation during active, unplanned pre-hospital resuscitation, and fails to engage with the evidence that informed clinical practice during the pandemic in the absence of evidence to the contrary and applying the precautionary principle, if that's clear.
I could see that practicing CPR could generate aerosols in that lowercase sense that we were talking about earlier on. It's not generating a mechanical spray of aerosols into the air in the way that uppercase AGPs are understood. But yes, it's a risky procedure. I don't dispute that. It carries risks. And there's therefore a need, for that risk to be mitigated through reliable evidence as to what would be helpful as a mitigatory approach and what would not be helpful. And that's a task that would need to be at some point addressed through randomised controlled trials. There are many randomised controlled trials in the field of emergency medicine, and this may be a research gap that hasn't yet been addressed.
Their third observation relates to B14 and B16, so it immediately follows that there, and it relates to personal protective equipment.
Yes.
And the college says that your responses here on personal protective equipment are unsatisfactory. They say that you repeatedly assert that there is no evidence to support the efficacy of masks outside hospital settings. Now, Mr. Gale discussed that with you this morning, but I just wanted to give you an opportunity to respond to that there is no evidence to support the efficacy of masks.
Yes. Well, that was the essence of my annex in my report, original report of July 2023, where I looked specifically at masks and particularly the most recent evidence, which was from the Danish study and the Bangladesh study. And then, you might recall, my lord, we finished with a forest plot, which actually, do you remember that? It was in tiny print, and there's the updated evidence as at 2023, and the conclusion was that medical surgical masks versus no masks in the community weren't shown to be especially beneficial. Is how it can be put in most simple terms, and that's on the basis of multiple randomized controlled trials, all converging to demonstrate that point.
Thank you. They also have some criticism of what you say under theme F1 in relation to pre-pandemic planning, but I'll come back to that very briefly. There's not a lot to say on theme F and theme G, but I will raise that later. It's just a short point. And then their further criticism is that in their words, they have concerns by Dr. Croft's weak and selective commentary on masks and respirators, which fails to acknowledge the weight of global evidence supporting their role in reducing transmission. That's their view. You have, in some detail, given your view both in your original report. Is there anything else you would want to add in response to that observation?
Well, only to say that I don't have a private view. All I can do is draw the attention of the inquiry to the best summary of the evidence, most reliable summary of the evidence, and that's, as I set out in Appendix 5 of my original report, where the evidence had been updated to take into account the most recent randomized controlled trials of that particular preventive measure, face mask wearing.
Now, I've put the substance of the College of Paramedics letter to you, and yes, you have said that you've, and I've seen a written response that you've provided. Is there anything else you want to say on that issue?
Well, only to say that randomized controlled trials are so important that they will often be completely counterintuitive and give results that are strikingly the opposite of what one would expect, and nevertheless they're adopted immediately by the medical fraternity because there is such confidence in the reliability of this sort of methodological approach. An example of a trial in the field of infectious diseases that changed practice overnight was there's a condition called Clostridium difficile diarrhea, now called Clostridioides difficile diarrhea, which is sort of very severe diarrhea. I'm sorry to talk about diarrhea. Very severe, and it's caused really by doctors who overprescribe antibiotics to patients, and in time the antibiotics can wipe out the normal gut flora, the beneficial gut flora, and this rather aggressive type of gut bacteria called C. difficile can take over and cause significant diarrhea as the body tries to eradicate it. And the treatment for it is very difficult. It can be life-threatening, the diarrhea. And essentially, patients have to be given a very strong antibiotic called vancomycin, which is, paradoxically, you give an antibiotic to treat a condition that's been caused by too many antibiotics. About 10 years ago, a Dutch team came up with the idea of instilling feces into the guts of the feces through tubes from healthy donors who had normal bacteria in their feces. So they did a randomized controlled trial where I think 600 patients in the Netherlands were randomized to either vancomycin, standard treatment, or this method of instilling feces through a tube straight into their gut. And the results were so striking that the trial was published in the New England Journal of Medicine, which is the most premier journal. We discussed that last time. And they're so striking they had to discontinue the trial because it was no longer ethical to withhold this strikingly good fecal instillation treatment from those those patients who'd randomly been assigned to vancomycin. The vancomycin group improved a little bit, but the fecally instillated group improved so dramatically that the trial was discontinued, but nevertheless provided this extremely important new method of treating this difficult condition. And it's now accepted as a standard condition for treating patients with C. difficile diarrhea that just on the basis of one trial that is good at all, well, far better than vancomycin, even if some people still use vancomycin because it's kind of easier. So that's the sort of impact that randomized controlled trials have on clinical practice that you would never get from an observational study. And doubtless there had been observational studies in the Netherlands and elsewhere suggesting that this might be useful, but only when a randomized controlled trial came along was there this dramatic shift in practice to embrace this new knowledge.
Thank you. Well, if we could now return to the tension, which, as I put it, which is a theme of the questions that have been put to you for the purposes of your supplemental report. And if we were to look, for example, at E2, the same theme emerges in E8, E11 and E13, the latter about the interaction of measures, which I'll come to in a moment. But if we were to begin with E2, the question that you were asked there was, you have focused heavily on evidence-based medicine, which you've explained. In the context of a developing public health situation, what is your understanding of the correct approach to outbreak management, and how does that sit alongside EBM? So the premise, I think, is that do they go together, or
yes,
do they complement each other and so on?
Yes. And to some extent that's been touched upon today already. Dr. Tegel talked about how the emphasis was on hand washing and social distancing. So those are two measures where evidence has shown benefit without any risk of harm occurring. So those measures were emphasised to start with. Cleaning environmental surfaces I don't think it had been rigorously investigated through randomised controlled trials, but it was seen to be something that was equivalent to hygiene and therefore logical and sensible and had no potential for harm at all. So those were the linchpins of evidence-based approach to the pandemic at the outset, and they proved beneficial in Sweden in slowing the course of the pandemic. In Sweden and within healthcare settings, healthcare staff were generally wearing face masks, face coverings. In the community, they were in countries where that was mandated. In countries where it wasn't mandated, they took individual decisions as to whether or not to wear them, often guided by government messaging. That second approach, logically, is more evidence-based than the imposition of face mask mandates, because face mask mandates in the community are not supported by the evidence to date.
I mean, in your answer to E2, you specifically say that the correct approach to the management of an infectious disease outbreak is no different to the correct approach to managing an individual patient. And this, I think, fits into E8, which I'll come to in a moment. But it's the idea that you're responding to one patient or two patients. But the point might be put to you that the practicalities of doing an RCT at the outbreak of an emerging pandemic are formidable.
There would always be obstacles to doing research. There are at any time, and not least time and resources and funding. But nevertheless, multiple RCTs were conducted during the pandemic in different fields: vaccines, drugs, and physical preventive measures, and mouth washing, mouth rinsing. So therefore, that argument doesn't really hold together, because it's disproved by the reality of what happened, which was that good research was being carried out even at the height of the pandemic.
And indeed, if we look at E8, the question there, which was from the Scottish Health Boards, National Services Scotland, Healthcare Improvement Scotland, and Public Health Scotland, The question at E8 was with regard specifically to randomised trials, what are the limitations on the reliance upon RCTs in developing a public health emergency? And you say there are none.
There are none, because we should rely on RCTs.
Yes. And then in relation to E11,
Yes.
and in relation to E11, sorry, I've had, you were asked there, how does the development of knowledge during a public health emergency fit into a model based on, on EBM?
Yes, and there's my response, E11. So the randomised controlled trials can contribute incrementally in the way that knowledge, scientific knowledge does develop incrementally. It doesn't often develop explosively, like as an example that I just gave of Clostridium difficile, where there was a massive breakthrough in knowledge just through one trial. But generally, trials contribute in a piecemeal fashion to the development of knowledge, and knowledge gradually becomes firmer, even though uncertainties will always remain. And this is a key dimension of evidence-based medicine, that the uncertainties are addressed, and there isn't an attempt to circumvent them by using poor quality science to assume a position of certainty when there is none. This is very much the Swedish position. They wanted to be cautious rather than unduly decisive and dangerously decisive.
Mm-hmm. I mean, one of the things we saw from the Ioannidis paper is that there was knowledge about the virus that was presenting. It was a novel virus, but it wasn't a complete unknown.
Correct.
And that there is perhaps a suggestion in some of these questions that they were dealing with something, we were dealing with something which we had no insight into at all. I mean, what would you say about that suggestion? We had no insight into this at all when it emerged in January, February 2020.
Well, this wasn't a virus that came entirely out of the blue. It was a coronavirus, and there were 7 coronaviruses. In my original report, I had a table describing the human coronaviruses, page 13 of my report. So the first one was identified in 1967, another one in 1967, and then we had SARS and MERS later on. So it was reasonable to conclude that this new coronavirus would have many of the characteristics of the existing coronaviruses. So there was some knowledge by association, even from the outset, and with the disease progressing rapidly, the knowledge did advance quite quickly. Although, just harking back to the Harrison's, what Harrison said, Harrison's emphasised that there was a flood of confusing and often contradictory evidence from non-randomised controlled trials, and early on there was still enormous amount of uncertainty around the prevention, diagnosis, treatment and prognosis of the disease remaining. So there was some knowledge, but a lot of uncertainty was what we were faced with. And much of that uncertainty is still with us. There are still some areas of COVID-19 and SARS-CoV-2 that haven't been satisfactorily resolved as yet.
Yes, I mean, in your answer to a later question, I won't take you to it just now, you refer to your view that no lessons were learned from Dame Deirdre Hines' report into the swine flu pandemic.
With that particular lesson, I think she had 22 recommendations, and the particular one that I highlighted was that there shouldn't be over-reliance on worst-case scenario forecasting. That one doesn't seem to have been learned, as far as I can see, but maybe some of the other ones were learned, yes.
What was the state of knowledge from the previous coronavirus experiences, which was there to be drawn on? I mean, is it your view that it was drawn on at the outset of this pandemic?
SARS did affect SARS and MERS. I can't recall whether MERS was affected in Britain at all, but SARS, there were some cases of SARS. It was a respiratory virus like any other respiratory agent. So, so the general knowledge about respiratory agents there was quite a bit of knowledge in existence, and that could be applied to SARS in the first instance, and was applied. To SARS-CoV-2. So there was, shall we say, a crossover of knowledge from the previous coronavirus experiences globally. But what was dangerous was that in China they'd undertaken this draconian measure for containing SARS, and that was lockdown. It was introduced in China, and that approach was adopted by a number of European countries, starting with Italy and France, I think, and then copied by Britain. And there was really no evidence that approach was effective without causing grave harm at the same time, because it hadn't been subjected to randomized control trial or even a proper evaluation. So that's where SARS was to some extent both a help and a hindrance. It was a help because we knew something about how coronaviruses behaved, but it was a hindrance in that the approach that had been adopted by one community, the Chinese Communist community, was followed in this country and other European countries, not in Sweden, and we live with the consequences now.
I mean, I don't want to belabor the point too much. It's my last question on the point, but it's exploring this question of novelty again, which I think is a premise in some of these questions.
Yes.
And going back to your malaria study, you said you didn't find what you expected.
Yes.
I mean, is it part of doing an RCT that when you see the result, when you see the symptoms and what's presenting and so on, and the RCTs are done, are you looking for similarities in the previous experience from randomized controlled trials during other coronaviruses? Is that what you're looking for? Or are you excluding that and looking for new things that exploring the unknown?
Yes, there will be some. There will be some reason to suspect similarities with a similar sort of structural pathogen, but every pathogen is different for a reason, and they will have different clinical presentations. So therefore, that's all part and parcel of the uncertainty that has to be ironed out through proper research in the course of time, but as soon as possible when the threat is imminent.
And can you say anything about the early randomized control trials and what they were showing in relation to COVID-19?
Well, the ones that happened very, very quickly were the vaccine trials, because as soon as the genome was published by China, the vaccine trials took off. So throughout 2020, vaccine trials were happening, and there were some treatment trials that were showing that generally antiviral drugs weren't beneficial in treating COVID-19, acute COVID-19. Dexamethasone as steroid was often helpful, however, and there were occasional physical barrier trials like the Mexican trials that had interesting results, and then there were the masking trials in Denmark and Bangladesh that really reinforced what was the evidence so far, that masking in the community wasn't particularly helpful in reducing the spread of an acute respiratory virus.
Now, well, that brings us, I think, neatly to E13, which is the other question that is in this field. And E13 moves on to public health measures, which is part of the response. So to be clear, your position is not that this should simply be left to medical research and RCTs. It is right that there are public health measures responding to the crisis.
Oh yes, and this type of crisis, of course, has been recurring since 1918. There have been these acute, worldwide respiratory global events. So this wasn't entirely new, and there were lessons learned from as far back as then. And the key lesson really was that you've got to wash your hands, you've got to be very rigorous about your personal hygiene and distance yourself from people around you. And that was emphasized early on.
Yes. If we look at this question, it is quite, as I say, it is a question that not only is about the interaction of measures of EBM, medical research, RCTs, but also public health measures. But in the question, it's the last part that I first of all want to ask you about. Even if EBM has not yet established the precise risk, I mean, was that the case? Were these early randomised control trials clear about what the risk was?
Randomised control trials are not there to define risk. They're there to propose solutions. So I don't think the question...
The presentation of the virus,
yes.
Were the risks arising from the virus known early on before public health measures were deployed?
Well, they were, and that brings me back to the table that I showed earlier on, the world map, March 2020, which has got a lot of circles. Yeah, that's this map here. So there was a lot of information to be gleaned from that as regards to risks, and by that time it was already apparent that large crowded environments and indoor spaces were breeding grounds for COVID-19, and it would already have been known that the elderly were at particular risk. So the risks were actually being gleaned from observation, but observation would help you to identify risks, but it won't tell you what the solutions are. No. The solutions have to be through other methods.
And so when the question asks would you accept other public health measures might need to be deployed to managing a developing public health emergency, we saw towards the end of Dr. Ioannidis' I probably pronounce that name in different ways, sorry, Ioannidis' report, that he, I think, suggested a graduated response, so hand washing, hand sanitizing,
yes.
Isolation to some extent,
yes.
reduced use of public transport,
yes.
Then reducing mass gatherings and
yes.
so forth.
Yes.
Would you agree? You agree with
yes.
that graduated response?
Of course, and provided that, and he makes that point very elegantly, that provided that those additional measures or that package of measures doesn't have this collateral damage that you get from the extreme measures.
Yes, and I mean your position is clear that the response, the graduated response, should at all times be based on the best available evidence.
Yes, of best available evidence of the benefit, and also an understanding that no harm would result. Yes, so that the two considerations need to be weighed side by side.
And the question in E14 is what sorts of measures exist within public health for the management of outbreaks. Well, we've addressed that in this graduated response.
Yes.
And then in E17, if I can look at E17, there is a specific question about the role of guidance. And you accept there that educating the public by way of guidance is one way of implementing control measures.
Yes, there will be some elements of behavioural change that can be left to the individual to impose on themselves or on those around them, and that is what, again, Dr. Tegnell was called, I keep forgetting what he calls it, the Swedish approach. The Swedish principle of voluntary action, yes, that's rather nice. So that's what they had, but we regrettably didn't have that. We had enforced action, by and large.
In relation to E19, this is relevant to one of the Rule 9 questions that came in, so I'll just put it to you. So in your report, in your supplemental report, in relation to E19, you were asked further, Antimicrobial Resistance and Healthcare Associated Infection Scotland, that's an organisation, produced a suite of rapid literature reviews to support the infection prevention and control response to the COVID-19 pandemic in Scotland. And they wanted to know, did you consider these rapid reviews? And you said you didn't consider them. And if not, why did you not consider them? And you've given your answer to that. You've fairly said you weren't aware of them. Now, in the Rule 9 question, which has been put, the statement is, and this is from the RCN, this is from the Royal College of Nurses, this was the last question that my learned friend left for me. They ask you, as their 13th question, Rule 9 question, it is noted that Dr. Croft was not asked to and therefore has not considered the organisation, the ARHAI's rapid review of literature, which informed infection prevention and control response taken by the Scottish Government. And the question now is, do you agree that the inquiry would benefit from reviewing that organisation's rapid literature reviews at a later stage, particularly when assessing the strategic response and the development of IPC guidance?
Well, that would be, it depends on the chair of the inquiry. I imagine very many of these rapid reviews that were put out, often perhaps updated every few weeks, possibly because they were rapid. And it may be the volume of literature that the task that's implied by this statement is very large. It may be quite small. If it was quite small, then there may be some benefit in reviewing them. Having said that, I can't really see why they would why they would in any way trump the Cochrane reviews, which are doing exactly that. They're looking at best quality evidence, synthesising it, and making recommendations based on the best quality evidence. And I can't see that the ARHA publications, good as they might be, would in any way differ from the Cochrane recommendations. Why should they differ if they're drawing on the same evidence? So there's no need to repeat the exercise we've already gone through. I would surmise. I would suggest.
Yes. All right. Thank you for that. Just going to another part of the themes in this section, Section E. We have to return to the question inevitably of measures. We've talked about the graduation of measures. And you've been clear that outside of a clinical setting, face masks do not assist in preventing the transmission of COVID.
Yes, there's no evidence to say that they do.
And going to the other extreme, if I can put it that way, of lockdowns, like Dr. Tegnell, you're also clear that lockdowns, there is no scientific evidence to support lockdowns as an appropriate measure.
There's no evidence from good quality research to support them as a measure for containing or slowing the spread of respiratory infections.
Yes. So if we look at an intermediate measure, which the questions in your certainly one question in your supplemental report addresses, which is the issue of contact tracing.
Yeah.
That is at E12. And equally, you're very sceptical, putting it mildly, that contact tracing is supported by gold standard research such as RCTs as a means of, as an appropriate measure to stop the spread or control the spread of a virus such as COVID-19. Is that correct?
Yes, I'm not aware of any randomised control trial that's addressed the question of how beneficial contact tracing is as a means of containing respiratory viruses. It is a procedure that is undertaken for sexually transmitted infections, but they're bacterial generally, and tuberculosis cases, but not for viruses that spread on this scale that we're talking about. So it was kind of an experiment that was tried in Britain and a few other countries. It may be the case that very small isolated communities could use that approach effectively, and I understand that in Singapore and Taiwan they did, because of the very limited and a small scale of their countries, they were able to use that type of approach to help to limit COVID-19 progression, but those countries, I think, are outliers. I would say and even then, I would still expect them. I would still expect there to be some kind of proper post-pandemic research into that type of approach to containing respiratory virus in the cold light of day. Now that we've got a breather before the next pandemic comes.
I mean, I don't want to put words in your mouth, but I mean, in my own words, lockdowns are not an appropriate response.
Right, yes.
Yeah, but you're not quite saying that contact tracing would always be an inappropriate response.
No,
if we just look at the question,
sure.
Would you accept that, there's two questions actually, would you accept that contact tracing is a significant aspect of the management of a public health emergency? I mean, so leaving aside or taking under advisement the word significant, right? What you say is yes, but only provided that this activity is demonstrably effective and cost effective and proportionate in the context of that emergency. So you're not saying no, never.
Yes, yes.
Right, so what exactly are you saying?
Well, for a start, the contact tracing programs were abandoned in the UK. A huge cost. I can't remember, was it 14 billion or something? An enormous cost. So therefore, it's just not prudent to adopt such expensive techno measures when they haven't really been properly trialled. It just sounded good to the politicians, and it was just something else that they could throw at the public in the Thursday Downing Street briefings. Perhaps that's a cynical view, but Taiwan and Singapore, they're small countries. People aren't moving around very much, and potentially contact tracing for this type of virus could be effective, given the very limited nature of their population. So the harm that results really is from the way it was conducted in Britain would be societal, because there were a very, very great number of false positives that were thrown up by the contact tracing scheme, as we've given to understand. So a lot of people were self-isolating needlessly, and that added to the general disruption of the economy. Many of those were healthcare workers, so it added to the undermining of the healthcare system, and whether or not there was any effective slowing of the rate of progression of the pandemic is debatable. I don't think there has been any evidence to suggest that it had any impact whatsoever on the rate of progression.
I mean, was there any randomised control trial of the effectiveness of contact tracing?
No.
So where did the idea for it come from, if you know?
Well, it came from Far East, I guess. It just seemed on paper to be something snazzy and modern because it involved mobile phones, but it was not something that really, with hindsight, was ever going to work. And people had to sign up and download an app, and I think only at their height, not even half the population ever did so. So it was doomed to failure.
I think there's some evidence from the Far East. I want to be very careful about this. I've read about it.
Yes.
I'm not quoting from it, but if you have a society, and I think South Korea is the one, where
yes, that's true. Yes.
A lot of people have mobile phones.
Yes.
But more importantly, the government has power to I don't know, use technology to obtain the information from them.
Yes.
Then it might be possible to have more effective contact tracing.
Yes.
But my understanding was that in societies such as Britain, where governments do not have such powers, it is not easy to have effective electronically monitored contact tracing. Now that's a fairly inexact, but I think it's broadly correct.
Yes. The Koreans are enthusiastic adopters of this sort of technology, I imagine, and so therefore they would have bought into the system in a manner that didn't happen in our own society.
Yeah. Sorry, Mr.
No, my learned friend and I were just looking at the timetable, and Mr. Gale mentioned workers' organisations representing their interests, and we were just wondering whether the timetable is correct, that we are going on to 1645.
I don't think it is. I mean, it matters not to me, but it says 1615 on mine, which would equate with, what did the audience, what were they told? 1615 or 1645, yes. There's lots of nods for 1615.
Well,
wonder why.
Well, let's see how far we get. But I mean, I'm on my last set of questions on E, and I think we'll finish it. But the questions I want to address you to now are in E22 and E23, which are questions from the Scottish ministers. And I suppose in light of what we've just been discussing, I mean, the segue is, what are public authorities meant to do? Contact tracing, well, they can try, it doesn't work. Lockdowns is disproportionate. You've got the various graduated responses that you have related, and also Mr. Ioannidis has set out, beginning with hand sanitising, limited use of public transport, stay at home, and so on. And I suppose governmental organisations, when they're seeing what's going on elsewhere, and from their perspective, they're concerned about various issues and the impact on resources, and particularly the hospital, they could say, well, what are we to do? In some ways, that is some part of the starting point of question E22. So what they say is, you refer to there being a hierarchy of evidence. However, you imply throughout the rest of the report that only evidence represented by RCTs or similar is acceptable as the basis of action. In the presence of a novel virus, well, you have commented on that, with no vaccines available and uncertainty regarding treatments, and there may be points you want to pick there, but let me ask the question. In the presence of a novel virus with no vaccines available and uncertainty regarding treatments, might it not be regarded as high risk in terms of level of mortality and hospitalisation to wait for RCT evidence before taking action on a population-wide basis?
Depends what that action was.
Yes. This is a variant on a question we've already had, really, I think,
well,
isn't it?
but
yes,
can we just unpick it for a moment? I mean, novel virus, you accept that, albeit...
Albeit it was a cousin of previous coronaviruses, yes.
No vaccines available and uncertainty regarding treatments, that's true.
Yeah.
Yeah, but what is your view then? Is it not high risk just to wait on RCTs?
Well, no, because there were plainly effective and efficacious measures available to slow the spread of the pandemic from the outset, and they were used sensibly and coherently and consistently in Sweden, and their ultimate experience was good, was fine. It had areas for improvement. But they didn't have to resort to untried and restrictive measures, what Dr. Ioannidis calls draconian measures, to achieve that ultimate escape from the national emergency. So RCTs were going on, but they were able to get to the same endpoint as ourselves, but without this idea of they weren't having to wait for RCTs. They just applied what knowledge was already available, and that was sufficient to achieve the desired survival of their society in a manner that was achieved with less pain than was achieved in Britain.
I mean, the next question from the Scottish ministers in E23 is, would you accept that the situation warranted a precautionary approach? So in discussions with my learned friend this morning, you talked about what you understood to be a precautionary approach.
Yes, yes.
So you would agree that the situation warranted a precautionary approach?
It warranted a cautious approach, but the precautionary principle, as was interpreted, was throw everything, regardless of the cost, and it didn't warrant that kind of approach of that Dr. Ioannidis calls the idea of eliminating the virus at all costs. That was not warranted.
Right. So a cautious approach would be the approach of graduated response.
On Sweden, a cautious approach informed by knowledge. Yes, that was prudent, and of course the goal was to.
If it's informed by knowledge, it's not cautious.
If it's informed by knowledge. Oh,
it is an approach which may be more limited than that which you might wish to implement. But if it's based on knowledge, then it is not cautious, even if the knowledge is rather limited, or if a better way to put it would be, even if what is available to you is regarded as a rather cautious approach or careful approach, it is still knowledge-based and therefore justified.
Yes. Thank my Lord.
And in fact, that complies with the precautionary principle. Because you don't go and do anything if you don't know what the results are going to be. That's not taking a precaution, that's idiotic.
Yep. It seems to be been a criticism that was levelled personally at Dr. Yanity, is that he was casting the precautionary principle aside. He's saying, I'm not casting it aside. I'm actually applying it in a prudent manner, informed by knowledge. Yes.
But would you accept that the precautionary principle is something that goes hand in hand with proportionality?
Yes, of course. Yeah.
And so once again, your view is that the precautionary principle wasn't adopted in the response to the pandemic.
Well, I think it wasn't adopted in a disproportionate manner. It was adopted in a proportionate manner in Sweden, but in this country it became out of proportion, because the measures that were adopted in the name of the precautionary principle were such that in some respects they caused more damage than was achieved by some of those measures.
You've made your position clear, Dr. Croft. Thank you for that. To be clear, my Lord, where I will go is very briefly to F and G tomorrow. There's very little to discuss under those themes, but a little more under H and the vaccines.
That's fine. We've got the time tomorrow morning. So
thank you.
That's fine.
Thank you, Dr. Croft.
Thank you, Dr. Croft.
Thank you very much.
We'll see you tomorrow morning. Is it 9:45 or 10 o'clock tomorrow morning? Does anybody know? 9:45. 10 o'clock, please. 9:30. Goodness gracious. Doesn't bother me, but it'd be nice to be told. 9:30, Dr. Croft. Very good. 9:30, gentlemen. Thank you all.